And welcome to Deuk Spine Institute. Welcome to our live stream AP. Our patient is from California. This is our second California patient for the day. And she has back pain that's coming from 3 of her discs in her lower back. If you look at the MRI on the bottom right corner, you can see there's unusual appearance of the L2-3, L3-4, L4-5 discs. So we are going in and I'm going to repair these 3 discs. We call the procedure the Deuk laser disc repair. Sean? Sean, I can feel the herniation. It's actually pretty good size here. One down. And we're doing from the right side L4-5, L3-4, and L2-3. We're going to make a little bit bigger incision than normal. And num. Shot. I'm putting numbing medicine so that it makes it more comfortable for her. She is still a little sleepy. We're waking her up. Shot. For those of you wondering what actually hurts below the skin, well, the skin itself does hurt. Shot. And there are certain tissues under the skin that hurt as well. They include the fascia of the muscle itself, the surrounding of blood vessels, and it's called the adventitia. Shot. All right. Now what's interesting about her is her spine is really posterior, meaning towards the back. Shot. Some patients, their spines are really far forward. Shot. All right, let's get an AP and see where we are. She has a spine that's really posterior. Go ahead. Shot. All right.
Right there, please.
You can see the needle position is really nice. It's just at the back of the disc on the L3-4. So I'm happy. And you can see the needle angle is very acute towards the skin, meaning that there's really, her spine is just really posterior. Shot. Really towards the back. Shot. All right. The L3-4 disc is the worst of the 3. Alrighty, we got one more needle to place on the right side, and then we're going to move over to the left. Do we have any more of the numbing medicine? Shot? Yep, that looks good. Wow. I may have to make a separate incision further north. Let's see. Now she's been on some type of anti-inflammatory, is that right? Yeah, so you can tell the ibuprofen because her blood is thinner than most patients. It's not, the platelet plug is not forming. It looks kind of watery, but it's starting to clot now. Shot? Okay, we're heading towards the L2-3 at this point. Shot? 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 I'm amazed at how posterior her spine is. It's probably the most posterior spine I've operated on in many years. Shot? AP? What I mean by that, the spine is up here towards her skin rather than being deep inside like so many patients. Cooker? I would say her spine is probably the most posterior spine I've seen. That's my AP. Shot. Wow. That L3-4 is really far across. Shot. That's amazing. How is she doing?
Doing okay? Yeah. Did you have any disc seal in your low back?
Yeah, she did.
Do you remember the level?
Shot.
4 levels of disc seal?
4 levels. So you had 4 levels of disc seal? AP. Okay, we've got these 3 in. We're going to have to go on the other side now. Coker or something? You guys should have that ready whenever you... All right, so that, let me just replace that 3-4. 3-4 was the worst? All right. Huh? Yeah, I know. In the MRI, 3-4 was the worst. You're right. I'm just impressed. Yes, I know you have scoliosis, so she's telling us right now. So you can see we've got our needles in at 4-5, 3-4, 2-3. We're almost done, by the way. We're doing a left 3-4, correct?
Yes, sir.
All right, just hang in there. We're almost done, okay? We're going to put you to sleep in a minute. Num-num. I was just talking about how far posterior your spine is compared to, yeah. It makes it easier. You are correct. In some ways. Shot? Now, don't be looking for a discount. I'm just kidding. But yes, it's nice that it's posterior. You are correct. So we're almost done accessing all the discs that we need to. And then we're going to test and we'll put you to sleep, okay? But you're doing great. Everything's going really well. Shot? You let me know if you have any pain in your leg, okay? Shot? Huh? Yeah, just localized in your back? All right. You're doing great. Again, I'm just so amazed at how shallow your spine is. Honestly, I think you take the prize for the shallowest spine I've ever operated on. I'm not kidding. I'm not kidding. You really do. I've been doing this many, many years. Not just endoscopic surgery, but, fusions. And I've never seen such a shallow spine. Sean? Where do you feel that? Where? In your back? AP. Yeah, that's one of your bad discs, okay? So let me just verify with everybody. We're going right 2-3, right 4-5, and bilateral 3-4. Everybody agrees? And that's the 3-4 we're about to go bilateral on. That's perfect, yeah. All right. Your scoliosis isn't that bad, by the way. It's a little bit. Certainly doesn't need to be corrected. Yeah, I know that's your unhappy place. Trust me, I get it. Hey, at least we found the bad disc, right? Wow. Yeah, I know. Try to relax. So she's tightening up so much I can't even get into the disc. You're doing great. Just relax. I may have to wait till she's asleep because she's tightening up. So this is a really good point for everybody to learn. When you tighten up your muscles here, it actually clamps down on your discs, and you can make it impossible to get into the disc. But I may have to wait for her to go to sleep to get in on the left side at 3-4. I just cannot get past the clamping down. You're doing great. Just relax. Everything's okay, okay? So you had the disc seal procedure done on 4 discs in your back. 3?
No, when did you have the disc seal? How many levels? What? How many levels?
When did you have it done?
Probably 5 years ago.
5 years? All right. Here you go. And they did it on 4 discs?
I believe so.
Okay. I'm going to ask you a couple of questions, and we're going to put you to sleep, okay? All right. So, folks, when I asked her, where is your pain, this is what she showed me. She said it's in this area here, okay? And when I looked at her MRI, indeed, there were 3 discs here that were damaged. The L4-5.
It's interesting that it's not L5-S1.
Yeah, it's not L5-S1. You're correct.
Which makes it a little easier to get in, right?
It is. Yeah. But let's not jinx this, okay? Let's not talk about easy. Believe it or not, it's still a hard surgery, but it is nice that it's not L5-S1. You are correct. And then we also know she has tenderness on her facet joints right here at L3-4. Are you comfy?
Yeah, I'm okay.
All right. How many of my surgeries have you watched before coming here?
5 or 6.
5 or 6. Okay. All right. How bad is that on a scale of 1 to 10? What's the highest?
I would say an 8.
8. And is that where you get your back pain?
Yeah.
All right. 8 out of 10, concordant.
Left, right?
Huh?
You have the left right there, right?
I'm on your, it's actually both sides. So it's not just the left.
I smell it more on the left.
Yeah, that's fine because it's going out both sides. All right. Is that better now?
Yeah.
Okay. How bad is that on a scale of 1 to 10?
10.
Is that where you get your pain?
Yes.
All right, sorry, that was the L3-4, by the way. That was the L...
Listen, where's something in the
Yeah, that's the one that you thought was the worst. It is the worst, 10 out of 10. The 4-5 was an 8 out of 10, concordant for both of them. Is it better now?
Yes.
Amazing how it goes away so quick, huh?
Yeah, that was the dye, right?
That was the dye. You are correct. So we're having a conversation for about another minute, and then she's going to go to sleep. You better now?
Yes, thank you. Oh, okay.
How bad is that on a scale of 1 to 10?
Probably 10.
10?
Yeah.
That was 2-3. That was a 10. Is that where you get your pain?
Yes.
All right. You get to go to sleep. When you wake up, that pain will be gone permanently. Not like this seal. This is for real.
Yeah, okay.
You like that? Not like this seal. This is for real. That's my new slogan. Not like this seal. This is for real. Or this is for real, not like this seal. Anyway, Henry, let's run our video on why do these disc herniations cause so much back pain for people. What's the basis of this back pain? How does it happen? Okay, welcome back. You can see from the video that the pain with these disc herniations comes from the annular tear in the back of the disc. That was discovered at Deuk Spine Institute. We're the first ones to describe it. We've been talking about it for now 12 years, 13 years. And we discovered that around 2009, 2010. You can see the tube we're about to use is about 7 millimeters from side to side, and the whole surgery endoscopically will be done through this tube. Our patient is extremely patriotic. She's red, white, and blue. She's from California, just as our last patient. By the way, I checked on the last patient, the cervical, and he's already leaving. He said he had no more pain in his neck. He was very happy. Yeah. He said, Dr. Deuk, you're the real deal. He's here with his lovely wife, and they are going to their hotel. So this is our second case for the day right now. She's also our most involved case of the day. The most levels treated, the most work being done. Thank you, Luis. We've got Nikki back in the operating room, assisting. All right, we are now inside the L4-5 disc. You can see the pink tissue, that's inflammatory tissue, just like you saw in the video. Inflammation is the reason why these patients have so much pain. You got to grab it properly, okay? All right, take that. Let's get the laser going. That is a herniation right there, within the inside of the annular tear. So the annular tear from outside to inside is about 1.5 centimeters or 15 millimeters on average. And we are now at the deepest part of the annular tear. It is also the least painful part. So the most pain happens when you get towards the outer periphery of the annular tear, the outer fibers. Any questions?
Yes, we have a question from Canes25 on YouTube.
Wait, before we do that, look at this disc. This is very unusual. This material here is very unusual. This should not be here. This, the blue stuff is the herniation, right? But this material right here is from the disc seal. Right there, I just zapped it and got rid of some of it, okay? This stuff right here, this is very unusual tissue. It's globular. And you shouldn't see globular stuff like that in a disc. So I think that's related to the disc seal procedure that she had done 6 years, we said? 5 years ago? Yeah, this stuff right here. Very unusual stuff. Come on. You got to do it right, okay? I don't know what you're doing. When I come here, you should be grabbing it like that and pinching it. That's it. Stop trying to do a Rockets maneuver on it. Yes, Canes25, we'll take your question.
They asked, Doc, if there's an interior tear on the disc, you don't touch that, right? I hope that's not a stupid question. I would assume there's no nerves for the inflammation to spread to.
Yeah, Canes25, you are correct. We do not fix anterior tears. The reason is simple. They are not painful. Hey, look at this irrigation draining off here. Okay? Can we do something about that, please? Yes, sir. Anterior and lateral tears on a disc, I have talked about it before. They do not cause pain. There are still fibers of pain on the side of the disc and the back and the front of the disc, but they're called visceral afferent fibers, VA. If you look up visceral afferent and Google it, you'll understand the difference between somatic afferents and visceral afferents. Visceral afferents do not cause sharp localized pain. Why is my irrigation stopped? No, I apologize. Somehow it got turned off. That's weird. We're good. I apologize. Something hit it and turned it off. I'm not sure what it was, but all right. Great question, Games 25. I'm glad you asked. Laser. I've addressed it in the past. It's worth talking about because it's a really valid question. And by the way, we discovered that concept here at Deuk Spine. So it's not like you can go to a neuroscience textbook today and find out that the anterior and lateral disc is innervated by visceral afferents and the posterior and posterolateral area is innervated by somatic afferents. That's something that we figured out here at Deuk Spine. We have not published that. It's actually very hard to prove that because the only way to prove it is to do neuronal tracking, which is where you inject the dye into a nerve and you can follow that dye over time as it travels along the nerve. The nerve would have to go from the disc all the way up to the brain, and there is no dye that does that. Come on. If you can't get it, you're going to have to step aside, okay? You're going to have to try a little harder. It's not a hand thing, okay? It's about not this, okay? I'm not targeting here. It's about putting it here, right? That's the target. It's a pinch. It's a pinch. It's not a like an ape hand. I give my staff about 10 times to get things right, and then I get frustrated after the 10th time. All right. Last chance, and then you're out of there. You understand? Luis is taking over. Okay? So you want it, you got to show me you want it, you got to earn it. You can't just have some bumblehead working next to me. Okay? Declare yourself. What are you? Are you a winner or are you a loser? This is time. I had to declare myself a winner many, many times in life. And I had to lose sometimes. And when I lost, I turned around and came back, and I came back a winner. Okay? Life doesn't accommodate losers. It accommodates the winners. That's Darwinian. Remember that. The losers die off. Just watch. This world has been around for billions of years. The losers of humanity will be around for another million, maybe if we're lucky, and then they'll be gone. There is no reward for losing. Our culture has become a reward the loser culture. I grew up in a reward the winner culture. As I've said before, playing basketball, there was one winner. You got a trophy if you won the championship. That's it. In soccer, you don't win the championship, you don't get a trophy. You get to sit there and watch the champions get a trophy. And it hurt like hell to watch that, especially if you have any dignity and pride. And that's the way it should be. Unfortunately, that's not the way it is today. All right, all this stuff, this disc looks very abnormal to me. By the way, I grew up in California, for those of you who want to know. Southern Cal, Conejo Valley. We were just talking about the rodeo earlier in our last surgery. That was the rodeo I used to go to as part of Conejo Valley days. Probably long gone. So this is a disc seal disc. And Henry, I'm not ready to do anything yet, but I do want to, I know we saw some weird stuff earlier.
I took pictures just in case.
Yeah, I appreciate that. I mean, that may be the best we're going to get. I mean, I don't know. We'll see. But this was a disc seal treated disc. And I want people to see what the disc seal stuff does. It congeals and forms a globulin, like a globular material. It's really scar tissue is what it forms. And that's what we saw, this globular scar tissue. But obviously it didn't prevent the disc from hurting, and the disc just continued to hurt. This stuff was seal. That's not normal to see this wad of scar tissue on the corner like this. Still nothing dramatic in terms of, wow, look at that, it's totally different. You know, I was kind of hoping for something that's more obvious. I'm just not seeing it, except for the globular stuff. All right, we'll take some more questions.
This next question comes from Samir on YouTube,
Uh-huh, I'll take Samir's question.
saying, Doc, I am scheduled for tomorrow. Can't wait. I have sent both neck and back MRI CDs. I was told that you will have 2 sessions, one for neck and one for back. One for neck, one for back.
Yes.
Is it right?
That is correct, Samir. The free MRI review, folks, is for one MRI review, either neck, back, thoracic. The second one is at a cost, so you will have to choose which one you want done tomorrow for free. Now, people that actually sign up and pay for surgery, they get their second MRI and third and fourth, however many they want, free. But we can't offer unlimited free MRIs to every human being on earth. Otherwise, I would never get any real work done. So, and I wouldn't be able to pay my staff, which are, it's a very high bills. So the only you get one free MRI review. The other one comes at a price. Now it's not expensive, it's like $99, okay? But that $99 goes towards paying some of our overhead. I don't put it in my pocket, if you're wondering. I think I've told you guys this before. I'm at a point in my career where I've made my money and I'm happy. At this point I have to pay bills. I'm not going to use my retirement to pay my staff and pay my bills. So we need money to pay bills, really is what it comes down to. And that's where all your payments go, paying the bills. Doesn't sound like a very good way to run a company, but you know, from my standpoint, if I can keep fixing people, I'll do it as long as I can. Unfortunately, we get no funding from the government. The government just takes money from us. We get no funding from private companies or private individuals, and we have to fight the insurance company on every dollar. And it's getting harder and harder to do that. Because the insurance companies, after all, they write the laws, and they write the laws so that they don't have to pay. They basically come in, have a free meal for their people, and then they leave and they don't pay. And they do it all the time. And they don't just do it to us, they do it to all the hospitals now. There are hospitals going out of business because insurance companies are not paying them enough money. They keep denying payments, not paying for the care that people receive. So very soon, America, you're going to realize the whole system is in a crisis. And it's been kept from you through the lies of the insurance company. Oh, you got great insurance, we cover this, we cover that. They tell you that, they sign a contract with a provider, and then when they don't pay us, we can't go after the patient. We actually can't even go after the insurance company, we have to sue them. And no lawyer will sue an insurance company unless they can make millions of dollars doing it. So to get to millions of dollars in damages, you have to have hundreds of patients. So it's a very convoluted system. But Samir, to answer your question, you get one free MRI review tomorrow, pick it, neck or back, doesn't matter to me, either one. And the other one you're either going to pay for or you're going to sign up for surgery and then you get it for free. That's how our policy works. I look forward to meeting you, giving you some answers.
We have another question.
Sure.
Yes,
We're
come.
just about done here with L4-5. You can see the epidural space. You can see the fat. By the way, for those of you wondering, this glass tube is 1 millimeter from side to side. So that gives you an idea of just how fat it is. Now look at that vein right there. Pretty cool, huh? Little vein. We call these veins Batson's plexus. Batson's plexus. And the laser actually can not just cut the vein, but it coagulates it so that it stops bleeding. The laser is a remarkable tool. Unfortunately, it's really hard to use the laser without having an endoscope. As a matter of fact, most surgeons don't use the laser, and that's because they don't do endoscopic surgery. If they did endoscopic surgery, they would all use the laser, because it's the only tool that really gets the work done endoscopically. Can't do endoscopic surgery effectively without it. Though there are doctors who try, they use other tools, but this is the best. The problem is it's very expensive to have a laser, to use a laser, to operate it, maintain it, to buy it. So most doctors don't buy lasers or use lasers because of the extra expense. Okay, looks like we're just about done here. And I'll take the question in a minute, but I want to look around. So the nerve root's going to be up here in that blue stuff, right above it. So there's still a little bit here that I want to get of the herniation. Boy, this disc looks really kind of trashed, right? And it's got a lot of this kind of fluffy-ish scar tissue. That's from the disc seal. Let's see if the next disc is a better one example, all right? Henry?
Copy that.
If it gives us a better view. The visibility on this stuff is not great. All right. 30 seconds. We should be done with this one. I will take additional questions.
This next question from Canes25 asking, what in God's name is disc seal? It sounds like a gimmick, more like disc steel.
Yeah, disc steel. You're right. It is a gimmick, in my opinion, okay? And it's a great idea in theory, in concept, okay? Stick a needle in the disc and seal the annular tear. But it doesn't work. That's the problem. And so, like many things that, sound great, right? It doesn't work. That's the problem. In reality, it doesn't work. So basically, they stick a needle in your disc and inject this material, collagenous material, that's supposed to create really an inflammatory response and cause, it's like a sticky mesh of fibers that are supposed to seal off the annular tear and prevent the herniation from getting worse. But it doesn't work. That's the problem. It just doesn't work. And the problem is they actually will inject a little bit of steroids while they do it so that the patients get some temporary relief, and they don't realize that temporary relief is not from the disc seal. It's actually from the steroid. Are we done with irrigation? Yeah. I think that's it. Let's just take one more look. Let me just see that. See, there's the fat around the nerve root. I want to clean this up just a little bit right here. Kind of a mess. This is where the disc seal was applied, so all there is scar tissue now. All this thick scar tissue from the disc seal. Nothing else.
So it's essentially kind of like the kypho with just like for the disc?
Like a what? Kypho?
Kypho for the disc?
No, I mean with a kyphoplasty you're injecting cement.
Right.
With the disc seal you're injecting a glue, fibrin glue. It's like a fibrin type of glue. All right, we're done with this disc. On to the next one. So I'm gonna put some antibiotic ointment. Scope off, thank you. Questions?
It's from Samir, once more on YouTube,
Uh-huh.
asking, Doc, does this treat cervical spondylosis?
Yes, this treats cervical spondylosis. Any kind of a disc problem, this surgery that we're doing, endoscopic surgery, can treat. It can treat herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc, degenerated disc, spondylitic disc, and even disc infection. We can treat an infection of a disc with, yeah, we've done it before. It's a great surgery for treating a disc infection because then you don't have to open the patient up and create any type of instability. You just go in straight to the disc and get rid of the infection. We actually have had patients come to us that have had infections from other spine centers. And they travel here, we go in, we clean out the infection, and we put in some antibiotics into the disc when we're done. and it clears up the infection. We can also get disc material to send off for culture. So that way we can get an identification on the organism growing. We do a gram stain and culture. So this surgery is the best surgery in the world for any disc problem. All right. The next one will be the L3-4, right, Luis? And because I could not get the needle in on the other side, you guys see the needle on the other side sitting out there just behind the disc? That's because she was clamping down. Now it's in. I just got it in. You guys see that? So
Yes, we do.
it's in now, but I couldn't get it in because she was tightening up her muscles earlier because the discogram. No, she's perfect. No deeper, no deeper. I just got it in. Yeah, shot? All right, now I'm going to take the needle out on this side, leaving the guide wire in. The guide wire will guide my dilator. This is the dilator. It's going to slide down this guide wire to the back of the disc. And I've just got to be careful. Like I said before, she has a very shallow spine. So I want to be careful. Her anatomy is not normal. Her anatomy is different. And you have to, as a surgeon, pay attention to each patient's individual anatomy. Shot? Okay, you have to make sure you're paying attention and trying to do everything to accommodate that patient's individual anatomy. Shot? Like in her case, I'm going to aim not as medial. I'm going to aim more lateral, okay? I'm right at the back of the disc. I can feel it. So I'm going to take my guide wire out, and I'm going to aim a little bit more lateral. And the reason for that is I want to keep my dilator lateral on the right side of the disc. I don't want it going across too much to the middle. Because when you have a shallow spine, that's what can happen. So we don't want that. We don't want to cut too much to the middle. You can actually end up on the other side of the disc in somebody like her. We don't want to do that. The most I really want is to go to 50% or halfway. Okay? So, any other questions? This is L3-4. Jordan, show us where where L5-S1 is. There's L5-S1, there's L4-5 up above, and then now we're at L3-4. Our last one up there is L2-3. So, we're done. Shot. Looks good. Fluoro out. Looks a little superficial, but it's fine. Questions?
Yes, this next question comes from Canes25, once more on YouTube, asking, remember you cured that guy from Mexico's infection? That was
Yes.
amazing, and his disc at the same time with the laser tube.
Yeah, that's the one I'm thinking of too. Yeah, he's from Puerto Rico. Yep, I remember. I remember it well. This is a great surgery for people with disc infections. Okay? And of course, it's better not to have a disc infection, but if you have one, this is what you want done. By the way, there's the needle from the other side. You guys see it?
Yes, we do.
We're going to have to pull it back just a little bit, just to get it out of my way. Hello. So I'm going to get it out of the way. Now, this disc is another disc that was treated with disc seal, okay? And it's not pretty. Not pretty. You got the tube?
Yes, sir.
You're not letting it pull back?
Yes, sir.
All right. Questions?
Yes, next question comes from Phil on YouTube.
Yeah, if I can get you something good here, Henry, I will.
Not a problem?
Look at all that inflammatory tissue, like deep inside the disc. But honestly, it looks like, to me, with this disc seal stuff and these discs, it looks just like really bad degenerated disc. It looks like, almost like it accelerated the degeneration of the disc. I'll take the next question.
Next question from Phil on YouTube, asking if the disc serves as a shock absorber to the spine. When a herniated disc is cleaned up without a fusion, don't I risk reherniation? Isn't there less disc? And what's keeping my vertebrae separated / stable?
Yeah, great question, Phil. So it turns out that we used to believe that, just like we used to believe that slavery was good. And then it turned out it's not so good. And it turns out that you don't need a cushion between your bones. So there was sort of this mass belief incorrectly that you need the cushion in between your bones. But the reality is, and what these doctors are not telling you, the lie, is that we see patients every day with no disc left, bone on bone, and they have zero pain, zero symptoms, and they are normal, buddy. And taking that person to surgery because they have, look at the size of this herniation coming out here. Look at this thing. Oh, mamacita. Right here. Oh my God, yes. Would you put that down and leave it? No, leave the ruler down. My God, come on. All right, there it is. Look at the chunk. Chunk. Okay, that was the herniation that was sitting in the foramen. Okay, and I shoved it back in with the dilator into the annular tear, and there it is. Feel how rubbery that is. Okay, it's totally rubbery. It feels like,
It does feel like shrimp.
yeah, well, they say it feels like, yeah, wet shrimp, right?
Yeah.
Look at the pink color right here. I don't know if you guys can see that. You guys see the pinkish hue to it? See the pinkish hue?
It's faded, but yeah, it's
It's very faded pink. That's all inflammation on that herniation. Can you see the pinkish color or not? Is it too hard to see?
that's not too hard
you
to
guys
see.
can see it, right?
Yeah. We can see the color.
Yeah, that is inflammatory tissue inflammation. So getting back to Phil's question, you do not need the disc between your vertebrae. It is not a cushion. That's what we believed for many years, and it really does act like a cushion, but it's not a necessary part of your disc. It's not necessary to have a normal, painless, what we call motion segment. Okay? Now, yes, I'm guilty of telling patients the same thing because that's what I was taught. And I just believed it, right? Because in life you have to believe some things that people tell you. And I was at a top neurosurgery program, and we were taught that that disc was needed, right, for a cushion. But then I started to see people that had no discs left, like 3 or 4 no disc, bone on bone. And they had no pain. Here's another piece of herniation. Not as big, but good size. And they had no symptoms, and I was like, how is this possible if the disc is needed, the cushion is needed to prevent bone-on-bone rubbing and pain? Why do these people have no pain where they have no disc? And the answer became quite obvious, and that is they don't need the disc in there. But where is the pain coming from then? And that's when I started to question everything I was taught. And I realized the pain is actually coming from right here, right where my laser is right now, the posterior annular tear. Nobody taught me that. I had to figure it out. And I figured it out by operating on thousands of patients' discs and getting rid of their pain by just fixing this little area in the back of the disc. Okay? Then I realized we were wrong the whole time. And all this that we were telling patients, you need a cushion, you need an artificial disc, you need a cage, you need a fusion. It was all wrong. They don't. So now I'm here sharing that knowledge with you. And the truth is that not everybody is going to believe it, and that's fine. I'm not trying to save every soul. I mean, it would be nice if they did, but, you know, when they discovered the world was round, there's still a lot of people who want to believe it's flat for whatever reason. And the proof, if you want to know the proof, is I'm not putting a cushion back in this disc, and their pain will be gone. Their disc pain will be completely gone. And if you don't believe me, go look at our testimonials. We have hundreds upon hundreds of testimonials of people that we fixed their pain in their back by cleaning their tear, but not doing, hold that tube, come on. I don't want to have to ask you again. Wait, let's take a look. The nerve root should be right out here, just in the foramen. Can't see it. There's some more scar tissue there. And that piece right there is concerning. It may be big enough to put pressure on the nerve because it's just below the nerve. So I got to get rid of it. I don't want her having problems from that.
Could the disc seal be pushing on the nerve?
Disc seal, no. The disc seal is gone. The disc seal turned into scar tissue. That's what disc seal does, by the way. A great question from Nikki. She said, could the disc seal be pushing on the nerve? The answer is no. The disc seal turns into scar tissue. Right? Isn't that crazy? Like, we don't want really scar tissue, but it turns into scar tissue. So, the problem with the things like disc seal is that they're really manufactured for one purpose, to make money. They don't care if it helps the patient. They're bought up by venture capitalists, money, private equity, angel investors looking to make a big return on their investment. So they buy into some technology that they can sell to the public as, wow, that sounds like disc seal, right? You got a tear, you got a herniation, why not seal it with disc seal? Sounds good. And then they get these suckers that buy in and they take them for all their money. Come on. And then the public pays the price because they're become publicly traded companies and all the people that invest in them end up being taken. Like the Wolf of Wall Street kind of taken. You know what I mean? Anyway, this patient's surgery is going very well. We're just about done on the right side at 3-4. I have to do the left side still. You can see the needle on the other side coming into the disc. I'm trying to stay away from it because I don't want to hit it with a laser too much. It'll melt it. Yeah, we're done here. Let's see. There's just that one thing I'm not happy about. I want to work on this just for a second. By the way, if you do endoscopic transforaminal surgery, make sure you look laterally. Don't always just look medial. For my first 50 cases, I only looked medial. And I didn't realize you're supposed to look lateral. And I left a pretty good sized herniation laterally one time. And the patient had symptoms and I had to go back and do it again. And I didn't know if they reherniated or if I left it, but now I look laterally every time just to make sure that there's nothing pushing on the nerve laterally. What I mean by laterally is I mean to this side towards me, not towards the middle. Most of the action is towards the middle. And only some disc herniations cause lateral compression in the foramen or extraforaminal space. And so I always look laterally at the end just to make sure I'm not missing anything. And I clean those herniations out. All right, questions for me?
This next question comes from Jamie on YouTube,
Uh-huh.
asking,
Nikki.
I have degenerative disc disease at L3-4, 4-5, and S1.
Yes.
Also have arthritis with bone spurs in my knee, so painful. If I could come there, are both surgeries possible, and how many days apart should they be done?
Yeah, great question. So thanks for asking. We do knees, and we do it with the Deuk plasma rhizotomy. It takes 15 minutes. There's virtually no bleeding. We would do that, say, on a Wednesday, and then we would do your disc surgery on either Tuesday or Thursday. So that's it. I mean, Come in on a Monday, have your back fixed on Tuesday, and have your knee fixed on Wednesday, go home on Thursday. We have lots of people who do that. Okay, 2 discs down and 2 sides to go. We got the L2-3, which is next from the right side. We've got our guide wire shot. I need to pull the needle out, leave the guide wire in place, and I'm going to use this guide wire to guide this thing, the dilator. You guys see this? Down the guide wire.
Yes, we do.
That way it goes where I want it to go. Shot? It doesn't just go off somewhere where it's not supposed to go. Remember, the hard part, in my opinion, of the surgery is the beginning where I'm placing those needles. Remember, I had the patient awake for that. I need her help. And she gave me great help. She was talking to me the whole time. And after that shot, the rest of the surgery can be done with her asleep, safely. Shot? Okay? And that's what we're doing right now. So, this is the L2-3. Now, her spine is very superficial or close to the surface, which is a good thing, and it can be also, there are some challenges that come from it as well. And so it's not all just good. But it also means the other structures in her abdomen are being pushed backwards as well. So you have to be very careful, you know, that you don't harm any of those things. Shot? Okay, we are now in the L2-3, and this will be our last disc on this side. She's doing fantastic. She's still asleep. She's doing well, doctor?
Yes.
Yeah.
Vital signs are great.
As Dr. Berndes would say, he has her in the plane, meaning she's sleeping comfortably, vitals are stable, she's not experiencing any pain or discomfort, and
Took her from business class to first class.
yeah, he said he took her from business class to first class. She's in first class right now. I think it's very funny. I like the analogy. Okay, here's another disc sealed disc. That does not look like a normal disc. If you watch this surgery with me, you know, you've probably seen hundreds of discs, some of our longtime viewers. That does not look like anything I normally see. You see the yellow streaking right there? I mean, we see the blue, we see the white, but the yellow stuff is weird. That's from her disc seal. All right, so Henry, you want to get that? And maybe, I don't know, that right there. I could stop the irrigation.
Doesn't really look therapeutic or
Hold
serve
on.
any purpose.
Is it too blurry for you, Henry? I could sharpen it up. Hold this, Luis.
It's a tad blurry, but I'm sure I can.
Let me see. How's that? Better?
Yeah, that's better.
All right.
me
So the
take a screenshot.
blobby, that's a good one. The blobby stuff is the disc seal. The yellowish stuff is the disc seal stuff. I don't normally see, like, there's a fiber right there. It's kind of never seen anything like that. So this is from, I believe, the disc seal procedure she's had done. Okay? And the reason we're getting all these pictures, folks, is our new website is going to show many of these types of surgeries that people go out and get done, ill-advised surgeries, and we're going to show you not just the surgeries and how they look, but also some of the complications from them. So you guys can understand, a lot of the spine surgeries that are being done today are bad for patients. They're dangerous, they're ineffective, and when you have something like the Deuk laser disc repair at your disposal, don't go out and have some crazy surgery, you know? I'll give you an example. You all see on the internet those people, they go to the amusement parks, right? I need it on. And like, I go to the amusement parks a lot. I go to Universal, Universal Studios in Florida. And here's the thing. When you go to Universal and you go on a roller coaster, you pretty much know you're okay. People don't fall off their roller coasters. The roller coasters don't like separate from the track and fly through the air with screaming people attached to them, you know. It just doesn't happen at Universal Studios because they are regulated by state laws that are very strict with respect to quality control, design, testing, for people's safety, okay? So when I go to Universal, I don't worry about the roller coaster coming off the track. But then you watch some of these amusement parks, like out in, I have patients from every state now, so I have to be very careful. Let's just say state X, some other state out in the Midwest that, you know, you go to one of those carnivals, right? Like I used to do when I was a kid, Canal Valley days. The carnies run it. And these things they put together like, you know, in a couple of hours while they're drinking Thunderball and high on meth. And you get on that roller coaster and there's a whole new level of scary because you honestly don't know, am I going to die? I mean, it's possible, right? Really possible. Because think about who put it together. You just look over there at that guy with the long hair with the clothes that hasn't been changed in a few weeks, and he's smoking a cigarette and his fingers are all burned from the crack pipe. The point is, it's a scary experience. I wouldn't go on those rides anymore now that I'm an adult and I know a little better. There's things I wouldn't do now that I used to do as a kid that I know better now that there's safety concerns. So it's the same thing as growing up and learning not to ride those very dangerous rides at the carnival. Okay, and instead go to Universal, spend the money. Yes, it's expensive, but it's damn well worth it. You're not going to die. You understand? That's how I see spine surgery now. It's no different. There's all these spine doctors out there performing procedures for patients that will lay down and take it. Just like there's carnivals out there that have rides for you, you know? And if you're willing and ignorant to go out there and do these treatments that other doctors are offering that don't work and are dangerous, then, you know, maybe you should rethink that decision. After all, you only got one spine. And God forbid somebody screws it up for you. You got to live with that. Hey, I'm getting a lot of debris. How's my irrigation? Good? You're changing it? All right. So my point is, if you're going to have spine surgery, do it right. If you're going to go on rides, go to a place that you can trust that has safety standards and they have high caliber scary rides, okay? It reminds me of when I went to Mexico a few years ago. I was at a resort and I was doing the zip line and I was probably 260 pounds. I was heavier than I am now. This is a couple of years ago. I've lost a little bit of weight. So I was 260 pounds and of course nobody speaks English there. And I'm looking at this harness for my ride. Oh, by the way, look at that, inflammatory tissue. Right there, Henry. That's beautiful. That's what we typically see, inflammation within the annular tear. That's where her back pain comes from. We don't need to, I mean, you're welcome to try to capture that, Henry, and send me a picture or two if you can. Let me shut off the irrigation. It's kind of pretty. Can you see the pink pretty well? Henry?
Yes, we can. Yeah, I was just taking a screenshot. It was
Hold
just
on.
a little blurry.
Yeah, but I can have it running or I can have it off.
Without irrigation?
So here's off,
Yeah,
go for it, but the blood is coming.
that's perfect.
See it?
Yep.
All right. So it'd be nice to see if we can add that one to our collection of granulation tissue within the annular tear.
Not a
That's
problem.
where all the pain comes from. All right, so I was saying I was getting on this zip line in Mexico a couple of years ago at a resort, and I was looking at the harness and I'm thinking, this is really skinny harness. And it's like stitched together in such a way that it's like, big weird stitches that look like somebody did it, you know, at home, you know what I mean? And I look at the guy and I say to him, "Is this safe for me to do?" And he says, "See." And I'm like, "Are you sure? I weigh 260 pounds. It's okay?" And he's like, "See, go ahead." And so I'm sitting there dangling literally 200 feet above the ground because their idea of zip lining is different than ours. Like we zip line, 30 feet up. They're 200 feet up in above the canopy. It's scary as hell. This was over in the Yucatan Peninsula near Cancun. And I got to tell you though, yes, I survived, obviously, but that was the most thrilling experience of my life because the whole time I'm thinking, I'm going to fall, right? And after all, why do you zip line? Because you want that fear of falling the whole time, right? Like, is this really safe? Am I going to fall? This is crazy. At least, that makes it more exciting if you're a thrill seeker. So I'm sitting there going, was this really a good idea, right? I'm here with my kids. I can't really chicken out. And I've just got to do this, bite the bullet and do it. But boy, when it comes to spine surgery, I don't think you should take those kind of risks. You should go with who you know is going to give you a great result. Excuse me. And go to a facility where you know it's very safe and they have the highest safety standards. So that's my advice. So far, everything's going well. This disc has got a lot more herniation than the other two. And thanks. And basically, I'm just cleaning it all out. Questions?
This next question comes from either Ram or Ram. Apologies if I pronounced that wrong.
Sure.
They said, "Dear Dr. Deuk, what percentage of your patients end up re-herniating the disc you repair and need another surgery? Thank you."
Great question, Ram. 1% re-herniate. 1 in 100 will re-herniate their disc. It does happen. I can't prevent it. All I can tell my patients is the kind of things they should, do to try to reduce the risk. But even if you do everything I tell you, there's still a small chance of re-herniating your disc, just with normal activities with following our instructions. So I've seen it happen. Re-herniations are real. They definitely happen. But the re-herniation rate for this surgery is far less than microdiscectomy surgery, okay? Far less. Microdiscectomy, the re-herniation rate is around 10 to 30%, depends on who does it. Yeah, ours is 1%. So microdiscectomy is 10 to 30 times higher. And the reason for that, Ram, is that with microdiscectomy, the surgeon is not debriding the annular tear with a laser. You see what I'm doing right now? I'm getting rid of the stuff that's preventing the tear from healing. Like this patient had disc seal. The goal of disc seal is to get the tear to heal, but it doesn't work, okay? And the reason disc seal doesn't work mostly is because the herniation is still stuck in the tear. And as long as the herniation is stuck in the tear, the disc will not seal, okay? So it should be disc no seal rather than disc seal. And the other problem is that the disc seal procedure doesn't remove the actual source of pain, okay? It doesn't remove the herniation. It doesn't debride the annular tear. The disc seal procedure just injects material into your disc. That's it. And hopes that it works. And it won't. That's like you in a professional football game. You're the quarterback. You close your eyes and you throw the ball downfield. And you hope somehow your receiver is going to catch it. You have no idea where your receiver is. You have no idea where the defensive players are. All you're doing is closing your eyes, throwing the ball, not even looking, but closing your eyes, throwing the ball, and hoping your teammates catch it. Now, those aren't good odds for me. Like when I do surgery, I want to know that my surgery is actually going to work. I mean, I expect every one of my patients' pain in their disc to go away. Disc pain. Not every pain, but disc pain. Like, I'm not fixing sacroiliac joint pain with this surgery. I'm not fixing piriformis pain with this surgery. I'm fixing disc pain. So I do expect my patient's disc pain to go away. And that's what I see happen. 99.5%, 99.5, basically 100% of the disc pain goes away with this surgery from the disc that we're treating. Of course, it won't take the pain away for the disc we don't treat. So if we recommend 4 discs be treated and the patient only does 1, well, the other 3 discs are still going to hurt, right? So I can't stop that. You know, people make choices. I don't choose what surgery to do for them. I just give them a recommendation of what I think they need done. Whether they get it done or not, it's up to them. But the reherniation rate is 1%. Great question. Thanks, Ron. And we have people go out and do things they're not supposed to do and reherniate, by the way. I won't mention any names. I won't mention what they did. But let's just say bending over at the waist or lifting anything heavy is like the #1 reason people reherniate in their back. Heavy lifting and bending. That's almost every single time I've seen a reherniation, it's tied to one of those 2 activities. And we tell people don't bend at your waist for 3 months, but they don't listen because they feel better. They think, oh, my pain's gone, I can do it. Yeah, your pain's gone because we got rid of the inflammation, but your tear is still there. And as long as the tear is still there, you're going to still have a risk. See the tear right there? This tear right here, that crack right there is why microdiscectomy doesn't work, because it never cleans this junk right here out. If you don't clean this junk out, you're not going to heal. It's kind of like getting a thorn in your finger and expecting your finger to heal over the thorn. It won't. The thorn is going to prevent the skin from healing, and it's just going to create chronic inflammation. This stuff here is like a thorn. It's not a piece of wood, but it's your disc material. Shouldn't be here. It's stuck in here, and it's preventing your body from healing. That's what I do with the laser. I clean it out. We call it the annular debridement. All right, great questions from our watchers. Any more?
Yes. Another question from Ram, once more on YouTube.
Robert?
On their follow-up question from their on their last one. They asked, "You are a genius. Is it because of the laser you use for the repair?"
That's what I do different than everybody else that does endoscopic surgery, Ram. So when I learned endoscopic surgery, I basically copied, on the lower back, I copied my mentor. I did everything, you know, put the needle, put the guide wire, went transforaminal, kept the patient awake, inside out. I did everything they taught me. And what I do different is the laser. And that's really, that's what I know is the reason I'm able to get rid of the back pain and the neck pain. It's the laser. It's the debridement. They don't do that. We were the first to describe it and publish it. I published it almost 12 years ago now in PubMed. If you look up Deuk laser disc repair in PubMed, you'll see that we published the annular debridement as part of our procedure. 2012 was the first publication. And then we've published it many times since then. Okay? So, am I a genius? I don't know. I don't think so. I think I just got lucky finding it and figuring it out, stumbling upon it, you know? I think it could have been anybody, any doctor that does this type of surgery, that pays attention to their results and wants to do what's best for their patient by doing things less invasive, safer, faster recovery. They could have figured it out. I think I just happened to be the one. I got lucky maybe. I don't know. I was willing to do something new, you know, something that other doctors, my peers, were not doing, you know, so maybe I just became lucky and I was able to do it. But I think all of us are capable of making these discoveries if we apply ourselves, apply our time, our thought, our knowledge. If we care enough, you can do great things in life, discover great things. I think it's within all of us. Of course, you know I don't do drugs or alcohol, so I think that helps keep a clear mind, a healthy body. I do pepperoni pizza. That's my only real vice. And that's with cheese stuffed crust. So I think, you know, having priorities. Right? I think having the right priorities in life will guide you and help you find things to help people. So, but thank you for your compliments. All right, we're just about done. I honestly thought I would be done a few minutes ago, but there seems to be no end to the amount of damage that was done to this disc. And I'm not going to stop working on it until I'm sure I've done everything I can do for this patient. She's traveled far to come here. She trusted me to care for her, so I want to do my best for her and every patient I treat. Okay, I think we're done with this disc, finally. Let me just take a look. You have to, yeah, so the nerve is going to be there in the fat, right there. You guys see the nerve, that white thing? It's just underneath there. A little vein on top, but the herniation's gone, and this tear will actually seal over. Look at how small it's already getting. When I pull the tube back, it's about 3 to 4 millimeters, so it's already closed up more than when I started. When I started, it was about 8 millimeters wide. Now it's about 4 millimeters wide. The most I've seen the tear close up from the surgery, during the surgery, is down to 1 millimeter. We had one the other day that closed down to 1 millimeter. It really depends on how healthy the annulus is after I've removed out all of the herniation and scar tissue. Like a really healthy annulus will close up right away. So, almost done, just irrigating. Little antibiotic stuff. Thank you. Any questions? We got one more disc to do. And then we got our Facet treatment for her facet pain, her DPR.
Yes, next question comes from Vitality Approach on YouTube.
Yes.
They ask, how does the no bending rule apply to the neck post-op?
Yeah. Okay, please be careful. So the no bending is no bending of your neck, not your lower back. So what we don't want you doing is flexing your neck forward, like touching your chin to your chest. So just so people understand the way the spine works is there's something called the instantaneous axis of rotation, or the IAR, biomechanically in a spine. And the instantaneous axis of rotation at a motion segment, which is the disc basically, the instantaneous axis of rotation is in the posterior half of the disc. So if you bend forward, you're compressing the front of the disc and you're opening the back of the disc, whether it's in the neck or the lower back. And what you don't want to do is squeeze the nuclear material in the front of the disc. You don't want to squeeze it to the back where the hole is, where we just fixed. So that's why we don't allow bending for disc surgery, is we want to avoid we want to avoid squeezing more herniation out, Sean, of the annular defect before it seals itself off. So, yep, that's the reason. Think about a seesaw, right? When somebody goes down, somebody goes up on the other side, or vice versa. So if you're squeezing down on the front of the disc, the back of the disc is opening. That's what you want to avoid. So for necks, we put people in a collar. Okay, now we're doing left 3-4. Oh wow, look at how much more open the disc is now that she's asleep and relaxed. Her muscles aren't clamping down. That thing is much wider than it was before. So I can actually feel the herniation. I'm pushing on it right now on this left side. It's firm. And I have to now smack it back into the disc with this mallet, and then I'm going to take it out. Shot.
So would the disc open up because it was bilateral? So we had
The
to put
disc
it
opened up because she's relaxed. The muscles aren't cramping down now anymore like they were. Take that guide wire out. We're in, like Flynn. Great audience participation. So we finished 3 discs on the right. We're going to fix 1 on the left, and then we're going to do her facets at L3-4. Shot? You can see the tube. Shot? Yeah, perfect. That should be good.
So that's the level up, right?
Fluoro out. Perfect. Great questions, folks. Great questions. So far, she's doing great. From an anesthesia standpoint, she's awesome. From a hemodynamic standpoint, she's awesome. From a surgery standpoint, getting stuff done, we're making great progress. We're almost done. Remember, she had back pain for how many years? 10 plus years. Okay, really bad the last 10 years. Huh?
She got it from moguls, skiing moguls.
Skiing mogul. She's a mogul skier. Ah, fascinating. Well, I'll be honest, I don't know that people get this from mogul skiing. I think she must have had a fall, you know, trauma, and that's probably what did it. But here's the thing. A year from yeah, a lot of axial, trust me, I know. 1 year from today, she can go back to mogul skiing. And I know mogul skiers, they love their skiing. They love skiing moguls. Ooh, and it looks like so much fun. I'm actually a boarder now. I don't ski anymore. I just snowboard, but I love my boarding every Christmas. Unfortunately, Utah has no snow. I mean, they've been pretty much dry the last few weeks. I think they got a little bit of snow, a couple of days, and that's it. Is the laser on? Thanks. All right. We got about 8 minutes left here, and then we're going to be done with this disc. We're going to get her DPR done, and then we're going to wake her up and send her on her merry way. Here's the tear. This is where the pain comes from. Questions?
This next question comes from Mike on YouTube.
Hello, Mike on YouTube. Welcome.
They ask, could stem cells injected after you clean up inflammation in the disc speed up recovery / healing of disc during your procedure?
Yeah, Mike, great question. And we get this question quite often, actually. We've tried it. We've tried the stem cells. We did it years ago, and it just caused so many problems for the patient we tried it on. She had tremendous pain and inflammation after her surgery, right where the stem cells were put in. So the stem cells actually cause inflammation, and they caused her to have severe pain. So I have stopped doing it because I don't see a benefit to it, okay? And I tell people I don't recommend it, but, you know, in the end, we're here to serve our patients. So if my patient said to me, Dr. Deuk, I've got to have stem cells, please put them in, I'll do it. I'll do it. But I'll warn my patient ahead of time. And I will tell them, listen, number one, it's expensive. Number two, I don't think it's going to add any value to your surgery. But if you really want it that bad, I'll do it. Okay? And I just don't recommend it. The disc is going to heal nice and beautifully with this surgery, as long as you don't re-injure it. And that's really the most important thing a patient can do. Avoid re-injuring the disc while they're healing. The healing takes about 12 months to do. So during your 12 months, just take it easy. You know, don't lift over 40 pounds. Don't go back to, you know, contact sports. Just take it easy and let your back heal. If you wait a year, that's all it takes. If you let it heal properly, you won't have this problem again. And you don't need stem cells. Okay? Most people don't understand what stem cells really are. We offer them. We don't promote them. We don't push them on people. But stem cells are just honestly, mostly, in my opinion, gimmick. Okay? They're really a gimmick. And medicine's full of gimmicks. And I'm not a gimmicky person. I don't promote gimmicks. I promote what works. And stem cells work temporarily in knees and hips, maybe a shoulder that has arthritis, knees that have arthritis. But now we have even better treatments for those things. So I don't really recommend stem cells. Does Patel do much stem cells anymore? No, we're done. Does Patel, he does sometimes. How many stem cell cases we do a year? Yes. 40 or 50 a year. And they're always for what? Big joints? What are they for? Knees, shoulders. Mostly knees and shoulders. So we do at Deuk Spine and Joint, we do apparently about 40 to 50 stem cell procedures a year. But it's typically in knees and shoulders is what I'm hearing, okay? I don't do them myself because I just do spine surgery, and I don't think they work for spine surgery, so I don't recommend them. I don't recommend things that don't work. You will never find me recommending some treatment that doesn't work, ever. I would rather retire from medicine and go live in the Caribbean scuba diving than lie to people about treatments, telling them something's going to work when it doesn't. I truly believe my treatments work, and I've seen them work. So that's why I recommend them, that's why I perform them. Careful now. All right. At this point, folks, we're going to move on to phase 2 of the surgery, which is fix the facet joints. She's got painful facet joints at L3-4 on both sides. I figured that out by examining her. So we're going to go in there and do a rhizotomy, a Deuk plasma rhizotomy, and basically treat those joints. Okay, there's the 3-4 facet. There's L3, there's L4, I can see it. So let's go ahead and do this. Need to put a little pressure here, so I'm going to start with the right side, the side opposite of what I've just finished. Hold on, and shot. All right, so there's 4-5, 3-4, 2-3. So I need to go for that target right. Remember, her spine is superficial, not in like a high schooly way. Shot. I'm right on the transverse process of 3. That's like perfect position. Where's the coker? Am I having it here? All right, take a shot. That's perfect. So right where that needle tip is, show us, Jordan, on that x-ray. You can see the transverse process and the pedicle of 3. Show us the pedicle of 3. That's, no, the pedicle. Right there, yeah, sorry. Stab incision, 3 millimeter, and here we go. Again, you're watching what's called the Deuk plasma rhizotomy. It's the future of rhizotomy treatments for facet pain. Shot. And it was developed here at Deuk Spine. It is, I get to say it now, it's patent pending, meaning that we have a patent for the United States Patent and Trade Office for this technology. Okay. And we haven't been awarded it yet, but it's pending. That's the perfect spot, right where you see it.
Thank you, Nikki.
All right, I'm slipping off, so I need to get back on there and figure out where we are. Let's see where this is. Hold on. Shot. Her, it's a little bit superior to where I want to be. Let's try this. Hold on. Shot. Now her muscles are jumping a little bit, so it's literally pushing me off my target. But I think we're okay. That's one down. Shot. That's nice. I can be a little more medial. But I'm feeling the facet. I feel the facet, which you need to feel. By the way, you need to stay on the bone. You cannot come off the bone here. Perfect. That's one. And then we got the other one we got to do a little further south towards the feet, the L4. That feels like it right there. Hold on. I got to move my hand out of the x-ray. Shot. Otherwise my hands will get fried with radiation. Unfortunately, these machines are, well, they deliver a dose of radiation for, navigation. But if you get enough, well, it becomes therapeutic. Only problem is I don't have anything to treat in my hands. So they end up doing some pretty bad stuff. If you get too much radiation directly to your hands, and you can get cancer in your hands. Let's see where this is. Wait, it slipped. Still slipped. And shot. All right, so right on the TP. That should be good. That should do it. Now let's come on to my side, left side. And shot. Yep, perfect. We're gonna put some numbing medicine. I'm gonna make a 3 millimeter incision. A little pressure there. We like to put a little numbing medicine. Huh? A little num-num for Dr. Berndes. Make him happy. Yeah, we're going to be done in 5 minutes maximum. If you have questions, type them up. But this lady has had a bilateral L3-4 Deuk laser disc repair and a right L4-5. And the right 2-3. Shot? All right, so I'm a little inferior and lateral. Shot?
Thank you.
Perfect. You agree, Jordan?
Yes.
And like I said, feel free to ask us questions. We like questions. We do questions and answers. So type them up. I'm going to come answer them for you in a moment. As soon as I'm done. That's one more down and one more left to go. Shot? 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 Well, I can feel a lot of scar tissue here at this L4. L3-4, but mostly the L4. Shot? Yeah, I know, Jordan. Shot? You got to make perfectly sure where you are before you activate the probe, because you can do a lot of damage if you're off. So I'm right on the bone of the TP right now. I feel good about that. Great job, everybody. Thank you, Luis. All done. Tough case. Type your questions up. Happy to answer them. Okay, Henry?
Copy that.
Hey, good morning. I'm Dr. R. Deuk, CEO and founder of the Deuk Spine and Deuk Joint Institute. I'm here with a patient who's traveled from Pittsburgh to Florida. And what brought you here to the Deuk Spine Institute?
Well, I have had back pain for so long, and anything and everything we didn't help. My wife did significant research. We found you online, actually, is how it started.
Excellent. And what kind of procedures did you have done before you came to Deuk Spine?
I've had 5 lower back surgeries, 1 fuse, and the others laminectomies and so on, all within the last 3 years.
And they were recommending another fusion for you, weren't they?
They were. That's when I really began to research other options. When they mentioned another fusing, I absolutely was not going to do that. So that began our research that ended up finding you.
The Deuk Spine Institute. And what we do differently, folks, is we cure pain with one procedure. Patients don't have to keep coming back having multiple procedures and pain management. And that's kind of where you were. You were in that surgery, pain management, surgery, pain management, surgery, pain management, back and forth. And that goes on if you keep doing it for the rest of your life. But you found a way to get out of pain and you came to Deuk Spine. How do you feel today?
Unbelievable. I have not felt this good in years, several years.
And you feeling good because we put you on some new pain pill that nobody else has?
Absolutely not. I've lived on pain pills up to this point. I'm on nothing. I have a prescription for some muscle relaxers, no pain pills. I'm on nothing.
And how did Deuk Spine Institute fix your back?
Had the L3-4, L4-5 laser surgery, and then the rhizotomy that was done a few days later. Combination of those two, I'm pain-free.
Yeah.
I'm really pain-free.
I'd just like to point out that you, like many people, had more than one source to your back pain. You had discs that were causing the back pain, facet joints that were causing the back pain, sacroiliac joints that were causing the back pain, I think a piriformis that was causing the back pain. And because you were walking so funny, you were getting bursitis and other pain in your leg from the iliotibial band. We had to identify every one of those sources and treat everyone properly. And once that was done, it eliminates the pain permanently.
I have dreamt of feeling this way for years. Teared up a little bit this morning when I woke up. I could get out of bed without holding on to the wall, or it was just an incredible feeling.
Well, I'm very happy for you, and you could see we did your surgery with the laser, cleaning out your discs. Where did you go for your spine care? Was it a good center?
Prior to coming here,
Yeah.
I was at 2 major medical facilities in Western Pennsylvania and Eastern Ohio. Went through a lot of pain with the different procedures and surgeries I had done, and had no relief.
And what were these other facilities, you can say?
UPMC and Cleveland Clinic.
Yeah, 2 of the top spine institutions in the world, right?
Yes.
Great reputation,
Yes.
and yet they couldn't get you out of pain.
No.
And they were just ping-ponging you between surgery and pain management, surgery and pain
That's
management.
exactly what happened. Yes.
And there's no hope for actually getting cured because they don't have the cure to back pain. We do. Unfortunately, we've been trying to share that cure with them, but they're not interested. They just want to keep doing fusions because, well, let's say it, fusions make a lot more money than laser surgery does. It's hundreds of thousands, if not millions of dollars over your lifetime. That said, I'm glad you're doing well. When are you guys heading home?
Getting on a plane in a couple hours.
All right, very good. Is there anything you want to tell people out there in final remark?
I would just say that Deuk Spine Institute has been a lifesaver for me, literally. I would highly recommend it. I was being ping-ponged around for 5 years. I have dreamt of feeling like I feel right now for a very long time. So I cannot thank you, Dr. Patel, your entire staff. Everybody's been just incredible.
That's what we're here for, my friend.
Thank you, Doctor.
Give people back their lives.
Yes, thank you, sir.
All right, now go enjoy your top golf.
I will now. I will now.
All right, let's get you out of here. I'm here with a patient of mine who traveled all the way from South Carolina to come to the Deuk Spine Institute. She's a healthcare provider herself. She's had some back issues. She had the Deuk laser disc repair yesterday, and she wants to share some of her experience with you. Tell us about your back pain and your leg pain before your surgery yesterday.
I had surgery on L4-L5, L5-S1, so my symptoms were classic. I had the sciatic pain that ran down my leg. Every once in a while my foot would go numb if it was pretty irritated. And then I had pain along the top side of my hip. So pretty normal type stuff. I was going to the chiropractor, I was getting massage therapy, I was starting on meds once I did imaging and made sure that this was actually a herniation and not just like a muscle pull or something. So I had kind of gone through all the things. Had back surgery in 2020 at another institute, and they did a microdiscectomy / laminectomy of L4-L5. I was good for maybe 2 years, almost 2.5. Before it re-herniated. So not the most fun in the world, because you expect whenever you go to have a procedure that it's fixed and your life will be ongoingly better. But I'm a nurse and I ride horses, so I'm pretty mobile all the time, and that kind of pain just really gets you down.
So why did you travel from South Carolina to Deuk Spine? What do we offer here that you couldn't find there?
I was on an internet, the great internet search, to find out more information. So to read more about spine surgeries, about how many times people relapse, like all what's involved. I surely didn't want to go up to a fusion because that's absolutely ridiculous. So I happened to find one of your videos on YouTube. You offered the laser therapy. I was just sold like almost as soon as I saw it, because it made sense to me.
Yeah, having the perspective of being a nurse and a healthcare provider, it makes sense. You're fixing the problem, debriding the disc tear, allowing it to heal naturally into a pain-free state. You had your surgery just yesterday.
Just yesterday.
Not even 24 hours ago. Were you in the hospital for your surgery? I
I was here in your surgery site. I got here around 1 o'clock-ish. Did all my pre-op stuff, rolled in probably around 1:35. I think our procedure lasted not quite an hour. I was out and eating dinner with my dad at 5 o'clock at a restaurant that your anesthesiologist recommended.
Oh, good.
Dr. B, he's great.
So no hospitalization.
No.
No morphine pump after surgery because you're in so much pain from
Not
the
at all.
surgery. No narcotic painkillers after surgery, right?
No.
What did you take for pain that we gave you? What new medicine did you take after surgery?
So I haven't taken any new medicine after surgery. I was on Robaxin and gabapentin prior to. Of course, I have to wean off gabapentin, so I did take my gabapentin this morning, but I didn't wake up in any pain. But unfortunately, that med you have to wean off of, so it's not like I can stop it to cold turkey.
Yeah, so basically we did a small incision. We went in with the laser and debrided your tear. And at the end, we had a tiny 7-8 millimeter incision. And there's really no pain after the surgery, so there's no need for narcotics. After your prior microdiscectomy, you probably needed to take some Percocets
that
or
was,
oxycodone.
just to roll out of bed, just to get up off the couch after
hurt.
that surgery.
It's painful.
It's painful.
Yeah.
It's absolutely painful.
And the difference, people ask me, what's the difference between Deuk laser disc repair and a microdiscectomy? The difference is a microdiscectomy goes straight into your spine. The surgeon has to pull all the muscles off your spine. Then they have to drill a hole in the bone to get to the disc. And they have to remove ligaments, and they have to take your facet joint partially out. There's so much destruction that goes on under the skin. The surgeons don't talk to the patients about it because
No, they didn't.
everybody does it. They think there's no better way, but there is a better way. It was developed by an Iranian orthopedic surgeon to come from the side. And I'm a student of one of his students, so second generation endoscopic surgeon, transforaminal. And it's a better surgery because it doesn't cause any damage to your spine or your body. It's wonderful.
It is wonderful, I'd have to say.
And how do you feel today? Is your preoperative pain gone?
Oh yes, all of that's gone. The only thing that I feel is like right in mid-spine where you basically stab me. And that's, you know.
Yeah, you know about
That's-
that. You watched the videos. Okay, well, I had to cut that one short so we could get to some of the questions. We just completed on a patient who's had 3 discs that were damaged, causing her pain. 1, 2, 3. This is the L5-S1 disc at the bottom. Hers was fine, no problem. But the first disc to cause pain was 4-5, 3-4, 2-3. Now, she had already had disc seal injected in these discs. She's had back pain for 10 years coming from these discs. And the disc seal didn't work. No surprise there. But we just went in, and on both sides at 3-4, I went in and repaired the tears and herniations on both sides. At 2-3 on the right, at 4-5 on the right. And all of my treatments are transforaminal, through the foramen. Everything went really well. We got everything done. Then at the end, I did the Deuk plasma rhizotomy at L3-L4 facet joint on both sides. I went in and basically burned the pain nerve here, and then on the other side, same place. So we completed the DPR, we completed the DLDR, we did everything we were supposed to do. She lost about 5 cc's of blood. That's about 5 times 20 or 100 drops of blood. So you can see the blood loss varies from patient to patient. One patient we had 1 drop of blood, now we had 100 drops. So why does the blood loss vary? Most likely due to the use of anti-inflammatories. That was quick.
Yeah, I just
Thank
took
you.
it from the script. You're good. You're welcome.
This patient used a lot of ibuprofen. The effects of ibuprofen do not go away after 1 week. Surgery becomes safe after 1 week, but the effects of ibuprofen last for around 21 to 30 days. So if you really want the complete effect of ibuprofen to be gone, then you have to stop it for a month before surgery. We don't recommend that. We recommend a week. Now there's going to be a little bit of excessive bleeding, but certainly nothing to write home about. Nothing that I'm concerned about. 5 cc's of blood is really nothing. It's a nosebleed, and it's not dangerous at all. If she had had open back surgery, that would be a different story. She would have had a laminectomy and fusion. I would have made an incision about that big. She would have lost, with me, maybe 100 cc's of blood. With other doctors, 500 to 1,000 cc's of blood, just because my technique is better. And she would have screws and rods and cages. That would have been an alternative surgery. I do not recommend that surgery. It's far too invasive and dangerous with complications and adjacent segment disease. So we did what we did today. It's the least invasive surgery that works. Questions?
First question, these first 2 questions come from Vitality Approach on
Low Vitality Approach. Welcome back.
First question they ask, do patients need to have a follow-up appointment with you after 6 weeks, and would you do that over Zoom? Wondering this for those who travel.
Great question, Vitality Approach. So the reality is, if you're my patient, I've operated on you, you can reach me anytime you want. As a matter of fact, all my patients get my cell phone number. They have it, and they can call me. I take the calls. My cell phone's always with me. So the reality is that people don't call, and when they have a problem, they're feeling some ache or pain, they will contact Sam or myself, and they will schedule a Zoom meeting. And that way I can see them, and I can see where they're having any issues. Like I said many times before, 10% of our patients will reach out to us in the weeks after surgery. They'll have an ache or pain somewhere. They want to know what's going on. And I can tell you 100% of the time, it never comes from where I operated. It's always somewhere else. Remember, there are 30 causes of back pain. And I may fix, like in this patient, we fixed 3 discs and 2 facet joints. So we fixed 5 sources of back pain, 5 common sources of back pain, 3 discs, 2 facets. But there's other facets and there's other discs that we didn't fix. And there's the piriformis muscles, there's the sacroiliac joints. So there's, fortunately, most people have 4 causes of back pain on average, but 4 or less, but 4 is the number. And few people have more than that. But we do have patients that have, gosh, I saw one up to 15 causes of back pain. And I can't remember, I think this person will have surgery on Thursday, if I'm not mistaken. They have 15 causes of back pain, out of 15 out of 30. That's a lot. And some of them I didn't diagnose over Zoom. I had to diagnose them here when they showed up on Monday. So, you know, the reality is that people, you know, with back pain, they don't have that back pain constantly. It's not, I mean, they may have constant pain, but it seems to get flared up with certain activities. And if I'm examining somebody, trying to figure out where their back pain is coming from, at that moment, if they don't have all their causes of back pain flared up, I can't, if one of the causes of back pain is not causing pain at that moment, I can't identify it. It's invisible to me as the diagnostician, and I'm one of the best in the world at doing this. So if I can't see it because there's no pain there, how am I going to know that that area is causing pain? So we see 10% of our patients have alternative sources of pain that were not diagnosed because they didn't have pain there when I was examining them before surgery. So we had no way of knowing that they had that pain. And then they're walking around afterwards and they start getting an ache or pain in something that we didn't know was painful. So they will contact me, we'll do a follow-up. But generally, nobody contacts me. 90% of the patients, they're fine, they just recover from surgery. There is no follow-up. They can follow up anytime they want. I don't make people follow up. That would be like the lady on the lunch line saying to you, hey, come back after your lunch and let me know if you had enough to eat. You'd be like, well, I'll come back if I haven't had enough to eat, but otherwise I got other things to do. So we don't make our patients follow up unless they have an issue, but the surgery is so minimally invasive they don't need follow-up. We don't see problems from the surgery, we just see alternative pain sources. That's typically what we'll see.
Next question from Vitality Approach on YouTube asking, are you able to tell the health of the annulus just by looking at it?
Am I able to tell the health of the annulus by looking at it? So Vitality, I don't know if you mean looking at it endoscopically or if you mean looking at it with an MRI. So an MRI scan is not really looking at something, it's kind of a computer generated image of what the computer thinks it should look like based on energy being released from water molecules within the tissue. It's kind of a crazy algorithm, and MRIs are wonderful, trust me.
Endoscopically, they just said.
Yeah, endoscopically. So, can I tell the health of the annulus? Yes, I can. You could see, for example, in this case, the annulus was torn, it was ragged, it was, it looked like it had been, put through a meat grinder, basically. And that's the way it typically looks from the inflammation and the damage from trauma. I don't really see normal annuluses because I don't operate on normal discs. So I wouldn't know what, endoscopically a normal annulus looks like. And I say that tongue in cheek, obviously, but we see various degrees of bad. And the nicest annuluses, like if you go back to the first surgery today, the guy with the neck, I was on his left side at C5-6. You could see the annulus was just ripped to shreds. The herniation was there. I got rid of it all. But as I was going to the right side, you saw this nice white pillow. And that is a normal annulus. There's nothing wrong with that annulus. And I left it alone. So a normal annulus is white and firm, and it doesn't have tears in it.
This next question comes from Betty on YouTube.
Hi, Betty.
Asking, hi, when you said not to bend for 3 months, would that be at the waist? Can you go to your knees or bend at your knees? And driving too?
Yeah, so Betty, great question. So what we want to avoid, the tear and the herniations in the back of the disc. This is the disc, this is front. We want to avoid people bending and compressing their disc and pushing pieces out. So can you bend with your back straight? Yes. If you can do that, absolutely, that's fine. Okay, but I don't encourage people to do that because some people's technique of bending is not so great. And I certainly don't want to encourage people to bend at their knees when they could actually hurt themselves. So, long story short, you can bend it, you can kind of squat with bending your knees and keeping your back straight. That's okay. Yes, as long as you're strong enough to do that. 90% of people we operate on don't have the strength in their quads to be able to do that. So I would never want them doing that because they're going to have bad form. As far as, what was the rest of her questions? Driving? You
Yeah,
can
driving.
drive the next day, the day after surgery. So this patient you just saw operate on, she can drive tomorrow. No problem. She'll wear a back brace, she'll sit in the car seat, and she can drive her car.
This next question comes from Rom, once more on YouTube, asking, do you recommend doing PT after laser disc repair? If yes, how many weeks post-op? After how many weeks post-op?
Well, so basically I recommend PT for everybody. However, I don't recommend they go to physical therapy. In other words, I recommend my patients do their own physical therapy. So what's the best physical therapy you can do after the surgery is walking every day, twice a day, 2 times a day, 20 minutes. Get out there, walk in the morning for 20 minutes, get out there, walk in the afternoon for 20 minutes for the first 2 weeks after surgery. Once you hit that 2-week mark, you've healed enough, I want you doing a mile once a day. And I want you to work on getting that mile under 15 minutes. So we call it the 15-minute mile. That is your therapy. You don't need to go to a physical therapist. The problem is I used to send patients to physical therapists, and then what happened was the patients, they would get, the physical therapist would mess up their back, mess up their neck, they'd have herniations, they'd have all kinds of problems. And I realized the physical therapist just cannot contain their enthusiasm for putting people through the, ringer, so to speak. Most physical therapists believe that more is better, so bend more, twist more, push more. And after this kind of surgery, it is not the kind of surgery physical therapists are used to doing physical therapy for. They don't understand what I'm doing in there. They've never seen it before. So they screw patients up big time. And, I stopped sending patients to physical therapy.
Next question from Vitality Approach, once more on YouTube, asking, does the herniation removal solve solve the issue of instability?
Does the herniation, I'm not sure of the question, but does the Deuk laser disc repair, the surgery just watched, solve the issue of instability? The answer is yes. The Deuk laser disc repair fixes instability of the spine.
And then last but not least from Steven on YouTube asking, how much time is allowed between steroid injection and surgery?
How much time, Stephen, is allowed between steroid injection and surgery? You can have your steroid injection done within a few days of the surgery, not a problem. We obviously would rather you not do that. The reason why, steroid injections inject steroids into your body. Those steroids go everywhere, they don't just stay in your spine. So they're going to affect your heart rate, they're going to affect your blood pressure, they're going to affect your kidney function, they're going to affect your immune system, they're going to affect your everything. Steroids work on every part of the body, even your brain. So you've heard of roid rage, I'm sure. So the thing about steroids that I would like is I'd rather you not have it for 2 weeks before your surgery, but if we had to do surgery within 2 weeks of getting a steroid injection, we could do it. But I would rather you let your physiology go back to normal before we stress you with surgery.
And that is for questions.
Wonderful. Thanks everybody for joining us. We've got another surgery coming up. The next lady, I don't remember where she's from.
Oh, Florida. Next
Florida.
two patients are Florida.
And she's having 4 discs repaired. L2-3, 3-4, 4-5, 5-1, all on her right side. So it's a right approach. We're going to go in there treating her back pain and her pinched nerves down her leg. She's got bad radiculopathy down her leg. She's got weakness in her leg, numbness in the leg. So we're going to go in and unpinch the nerves to restore function to her leg. And then we're going to treat her back pain by cleaning the annular tear with the laser. So she'll be a 4-level. I'll probably have to do 2 separate incisions. We'll get 2 discs with one, and then we'll get the other 2 discs with the other. We'll start that in about 30 minutes. Thanks for joining.